Everyone, thanks for joining us for this episode of Lessons in Dementia. Lessons in Dementia is a program at the Senior Resource Center. I'm Wendy Starr, I'm the director of Humboldt not Humboldt Senior Resource Center. I'm the director of Adult Day Health and Alzheimer's Services, and we provide therapeutic day programs for people with disabilities age 18 and above, and we have day centers in Eureka and Fortune. So today's episode of Lessons in Dementia is entitled Dementia and Research, and is being presented by Dr. Jennifer Heidmann, who is the medical director with Redwood Coast PACE. As a reminder, as you just saw the click-through, that this live session is being recorded, and you can find this episode and past episodes of Lessons in Dementia on our website, which we'll put the link down in the chat. It's www.humsenior.org. And there will be a brief survey at the end of today's session. Your response will help us to continue to provide content that's useful and relevant. And we do thank you in advance for taking a moment to fill out that survey at the end of the presentation. Now I'm going to turn this over to Caitlin Green, our Alzheimer's Services Coordinator. And Caitlin, take it away.
Thank you, Wendy. Thank you, everyone, for being here today. It's a great appreciation that people keep continuing to support this workshop. And thank you, Dr. Heidmann, for being willing to be our presenter today. As Wendy said, Dr. Heidmann is the medical director for the PACE program here for Redwood Coast PACE. And today she'll be talking to us about the science and understanding dementia and approaches to the diagnosis, and exploring some future research around care. And so, Jennifer, I'll pass it off to you. Thank you.
Thank you, Wendy and Caitlin. So is everyone hearing me okay? Okay, yeah. Great. So it's a pretty big little talk I'm going to give today, and I am hoping that people will have questions and you can put them in the chat, or and we can do them as we go and or at the end, whatever works best for everyone. What I'd like to say about this talk ahead of time is that it's a pretty convoluted thing, research in dementia. So I'm, mainly focusing on Alzheimer type dementia, but it's important to remember that although sometimes we can fairly clearly diagnose people with specifically Alzheimer type dementia, and I'll talk a little bit about how we do that. It's more often that people have a mixed picture, more than one cause, more than one of the over 70 causes of dementia. And we can infer the main types of diagnosis from our clinical acumen and picture and risk factors. But for the purpose of this talk, the majority of research people are referring to Alzheimer type dementia. So. Okay, and let's see first if I can get my slides will not move. I'm not quite sure why. So first I want to talk a little bit about science, and so how do we do science? It's been a somewhat contentious area in our society in the last few years. People's trust in science, and maybe not a complete understanding of how science works in healthcare. But there is an accepted method to research, and basically, first of all, there's a question that someone wants to answer. It might be, does this medication help people with Alzheimer's type dementia, that kind of thing. And then when someone has a question, before they start doing research, they have to put it in front of a board that looks to make sure that the study is humane, ethical, that we're following all the appropriate ethical standards. And then for a study to be considered decent, it really has to have a lot of diverse participants in the study. It should be randomized, which means that you may the person who's doing the study doesn't necessarily know who's receiving the treatment and who's not, and they're not choosing, like cherry picking people to get the treatment, but they're trying to make it as little bias as possible. And then you want it to be big enough and long enough so that the answers you're getting from it can be applied in a more broad sense. And then it should be reproducible by other scientists, and before it's, you know, put out there in the world or in the journals, it should be reviewed by peers who are considered experts in the field. So in dementia, it's even more complicated than in some other areas of research. And you know, some of the things that we have to contend with are with, let's say, Alzheimer's type dementia, is we don't 100% know exactly what causes it. We know what's associated with it, but not necessarily what really causes it. And the other challenging part for research is that often the damage that we see once we diagnose someone with dementia has been starting years, decades prior. So how can we find out who the people at risk are before they have irreversible damage to their brains? Because it's harder to fix it once you're at that point. If we find those people, it could take decades to know what works. So what do we do in the meantime? And then there's the ethical side of this, of who's funding the research, who's benefiting from the research in terms of like a business model, and you know, do we sometimes see money going towards research because it benefits people more from a business model than from a clinical model? And then I am going to explore areas of study other than just treatments and drugs for dementia. And I do want to talk a little bit about dementia itself as a term. It's a very non-specific, non-concise term. It comes from the Latin of out of one's mind, which really is not very nice, first of all, but it's really a very imprecise way to describe a clinical problem. To be diagnosed with dementia, you have to both meet criteria on objective testing, and I'll talk a little bit about the testing we do, and it should have an impact on your day-to-day function. So you may have some memory loss, but if you're still going to work and you know, really functioning without it affecting you at all, then we call that mild cognitive impairment, and we don't call that dementia. And dementia is not considered a normal part of aging. However, it is much more common as we age, so the prevalence increases. And like I said before, there's many, many causes. There's at least 70 causes. And, you know, in order to like move towards treatment or even a cure, we really have to kind of know the causes down to the cellular level. Having some technical difficulty. Okay, so the most common types of dementia, Alzheimer type, Lewy body, vascular, and frontotemporal. And some of you may have heard these terms, but essentially they're all defined by what part of the brain is affected and the symptoms that we see with them. And really, in reality, often people have more than one type of dementia at the same time, which further complicates research and treatment. And, you know, I talk a little, this is a kind of a busy slide, but if you think about the brain is this amazing, you know, thing that we have that has different lobes, different parts that have different functions. So, you know, the frontal lobe, I think of that as sort of the executive office. So up here up front is where you kind of plan and see the big picture and, you know, get things done. And then you have the memory area in the temporal lobe. And in the occipital lobe, it's sort of like visual spatial recognition and so on. So when you have the damage that causes these syndromes that we call dementia, it's because cells in these different areas of the brain are affected. And you might have one area that's functioning just fine and another that's not functioning well. Now we've all become accustomed to the term pandemic, and really dementia is a global pandemic. With every 4 seconds, a new person's getting diagnosed. You know, we're thinking about ourselves here in the United States, but the prevalence of people living with dementia are actually in lower and middle income countries. And in the Western area and North and South America, it tends to be more elderly, like in the 80s to 90s. In Africa, more younger in the 70s to 80s. And what we do see is worldwide that there's a lot of strain and economic fallout around caring for people with dementia, which is, again, something I'll talk about more as we go. It's expensive. This is back, data back to 2010, $604 billion globally for the cost of care, and it's supposed to go up 85% by 2030. And actually, it's more costly in the higher income countries, probably around the fact that people are more likely to hire caregivers or have to place people into a congregate living setting. And compared to other chronic illnesses around the world, dementia seems to have the largest impact on the needs of care for people. So heart failure and diabetes, other chronic diseases don't have as much of an impact on how much care people need. So focusing in on Alzheimer's, first of all, how did it get its name? Well, it came from this doctor, Dr. Alzheimer, and Augusta Dieter is basically the first patient that was diagnosed with this syndrome that took on his name. And she was pretty young. I think she was in her 50s when she came to the hospital where Alzheimer worked in Germany. And, her husband basically wasn't able to care for her and brought her in for treatment. So she, we should really tip our hat to Augusta, who, her brain tissue basically has given us the basis for research around Alzheimer's type dementia. And what Alzheimer saw was that when he looked at her brain under the microscope after she died was that she had these amyloid plaques and neurofibrillary tangles. And these are basically these findings that we associate with Alzheimer's type dementia. And kind of a cool thing is many, many, many years later, modern scientists rediscovered the slides with her brain tissue, and they were able to do genetic testing on it. And they found this mutation on a certain chromosome, pre-senilin 1, and saw that basically it showed that she had a really rare syndrome, which is early onset Alzheimer's disease due to an autosomal dominant inherited trait, which is like less than 2% of Alzheimer's is from this. And autosomal dominant just means like you're pretty much going to get it. It's a gene that's going to come to you and you're going to express the trait. That being said, a family history of dementia does not mean you will develop dementia. This particular syndrome that Augusta had is extremely rare. So early onset Alzheimer's in general means it's before age 65. And again, it's less than 10% of cases. Her, Augusta's particular mutation is less than 2%, but there might be other gene mutations involved. And I list some of them here. this particular gene, ApoE, apolipoprotein E, has gotten a lot of airtime, and it's something that might actually be tested. Maybe some of people have been tested for this. And it's interesting. We know it affects tau and amyloid in the brain, but depending upon your mutation or your variant of this gene, it might either increase or decrease your risk of developing Alzheimer's dementia. So again, it just kind of goes to show you that there's a lot of complexity to this whole thing. So what do we do with all of this information about genes? Well, certainly the early onset, we have a better idea what to do, especially the very rare autosomal dominant inheritance with Augusta Dieter. We know that there's probably some genetic component to late onset Alzheimer's, but it's much less clear. And we're not generally doing genetic testing on everyone. And there's a reason for that. Part of it is the implications that can come with that. So one thing is potentially it's a source for being denied insurance coverage if people think you're at risk for this. And also just the psychological aspect. So you may or may not develop Alzheimer's because you have this gene is not really a very helpful piece of information for someone, and it might be really stressful for them. So if genetic testing is going to be done, there needs to be counseling with a genetic counselor, and obviously consent needs to be given. Now, the flip side of that is that the more people that we do genetic testing on, the better we can understand that aspect of this disease, and it might help us develop treatment. And there actually is an ongoing study by the National Institute on Aging to better understand genes. And it's you'll see here, it's called the ADSP, or Alzheimer's Disease Sequencing Project, and it's more than 62 institutions around the world and more than 345 scientists, and they're basically trying to understand the function of these genes and among a more diverse group of people. So another thing about science research, at least in our country and in the Western world, is that it's been fairly homogenous around age, younger age, men and white men. So we need to really have a more diverse pool. So anyway, if you want to read more about this, this website is available. I think it's a very interesting project. So kind of back to, these amyloid plaques and neurofibrillary tangles. I mean, they look like they wouldn't be helpful to brain function. If you can see in the slide that you have healthy cells are nice and crisp looking, and then when you have the Alzheimer's cells, there's sort of some smudge there, and it's probably not helping, the impulses in our brain travel well, but it's still not exactly clear what role they play in the disease. And, there's probably some reason why these things build up. Maybe they're protective at some point in life around an infection. I don't talk about that a lot in this presentation, but there is a whole group of research looking at possible infectious reasons behind Alzheimer's. And maybe there's some protective thing that happens with these things that later cause problems. We just don't know yet. So how can we diagnose this? We can actually do what's called a lumbar puncture, and that's where basically a doctor will numb up the skin and put a needle into your lower spine. The lumbar spine is like the low part of your back, and suck out fluid from the fluid that sort of is around the spinal cord and brain, and then test it for these proteins that might be indicative of Alzheimer's type dementia. The holy grail right now is a blood test. And there are some blood tests, but they're not really ready for prime time. We're still not quite sure what they mean and how to use them. Again, we don't want to just test someone with a test that has a lot of false positives or false negatives. We want to make sure it's a good test. We do some special PET scans and MRIs, which are pictures of the brain, mostly used in research at this point. And again, alone can't really make a 100% diagnosis. And then, of course, doctors who are diagnosing this should be looking at other underlying causes, vitamin deficiencies such as B12 or thiamine, thyroid problems, electrolyte disorders, drugs that we are prescribing, illicit drugs that people are taking. Severe depression can look a lot like dementia. So those are the kind of things we need to kind of rule out. Now, obviously, a brain biopsy is pretty invasive, and we're not doing that in part because, if you think back to the other slide I showed with all the different parts of the brain, there might be a small section that's affected, and which section do you go to? So it's not really practical or safe at this point. EEGs might be done if we're worried about some sort of seizure type thing and to get a better idea of the brain waves. But really, mainly, it's still what we call a clinical diagnosis, which means we talk to people and we do a good examination. So that's sort of where we're at with testing for the disease. And again, if you think about the arc of the disease, the damage that leads to the symptoms that we see is probably starting 20, 30, 40 years before the actual symptoms occur when the diagnosis is made. So it would be great to have a way to capture a diagnosis early, and also so we could study treatments in people who might be at risk. So thinking about treatments, really drugs mainly at this point, we think about what we know about the disease and what we can target. So, and I'll talk more about each of these, but anticholinergic drugs, looking at the amyloid plaques to see if getting rid of that smudge could help, and as well as the neurofibrillary tangles, reducing oxidative damage. I'm sure you guys have seen on the shelves antioxidants, and there's some validity to that we know that that's damaging to tissues, genes like I discussed. And then ideally, because there's so many moving parts that cause these problems, we could find a drug that could target more than one factor. So just starting with sort of the mainstay, Aricept, donepezil. So these are the cholinesterase inhibitors, and they basically, there's these chemicals in the brain, and we think that when acetylcholine, this chemical, is low, that there's increased damage to the neurons or the cells in the brain. So they developed these cholinesterase inhibitors. Cholinesterase basically breaks down acetylcholine, so we're keeping it from breaking it down so much. It's usually offered in mild to moderate Alzheimer's type dementia. And again, because we can't always completely say it's 100% Alzheimer's, people may have some vascular dementia, but we think there's probably also some Alzheimer's going on, so we might offer it in that case, even though it's not indicated for vascular dementia. We don't really, unfortunately, this doesn't work all that great. It might help with some symptoms that people have, but it's not really going to change the trajectory of the disease. And again, most of the data is in Alzheimer's dementia, but it's sometimes used in overlap syndromes. And, unfortunately, like as a clinician, you want to have tools in your belt to help people. But what we're seeing is these drugs don't really help much in people who have that more mild cognitive impairment, which is when you'd like to be able to start treating so people don't end up with symptoms. And it really shows no benefit in terms of progression to dementia. And there's quite a few side effects, actually. A lot of people can't tolerate these drugs, especially around like diarrhea and upset stomach, weight loss, that kind of thing. So another drug you may have heard of, Namenda, memantine. The name Namenda comes from the fact that they block these N-methyl D-aspartate receptor blocker, so Namenda. And we think it probably lessens nerve damage because of, like, on the cellular level, how it's working. It's meant for use in moderate to severe Alzheimer's dementia, sometimes used in mild Alzheimer's type dementia, but that's off-label. And there might be some symptomatic improvement, but it's pretty small. It is pretty well tolerated. And what I've noticed clinically with this is basically if it's helping people like function a little better and helping maybe with some behavioral issues, continue it. If you're on it for several months and it's not doing anything, then you should probably just stop it with all these meds. Moving on to the really hot topic right now are these biologic drugs, the injected infused drugs that decrease that amyloid deposition in the brain. And again, we think that that's a good target because going all the way back to Dr. Alzheimer, that's what he saw in her brain. And we see it in people who have all the criteria to meet the diagnosis of dementia. Unfortunately, the first drug that was approved, which was in 2021, it was approved despite the fact that it didn't really seem to work. And there was so much controversy in my profession about that. It does reduce amyloid, but there was no real like evidence that helps people. And it's extremely complicated. You have to get these imaging studies done. You have to get that lumbar puncture, which is an invasive test. You have to get MRIs regularly. There's brain swelling and bleeding that can happen with it. It's if you just pay for the drug and the infusion, you're talking $50,000 to $60,000 a year. And it was, kind of touted as, yay, we finally have a treatment. And I felt a little bit like it was giving people false hope. Now, since then, we do have another drug, lecanemab, that's been approved. And this, again, going back to my very beginning of my talk, talking about the scientific process, this kind of skipped some of the steps. It was rushed to approval, again, because everyone really wants to find something that works for this. It does reduce, again, those plaques in the brain. It was tested in early Alzheimer's disease for about a little, like a year and a half. It was Europe, North America, and Asia, less than 2,000 people, ages 50 to 90, but tended towards younger people. It did have that placebo control, so that's good. And as often it is, people of color were underrepresented. What they saw is that both groups, the ones that were treated with the sugar infusion versus the real infusion, they saw that the people with the real infusion had less decline than the people with the placebo in their test for cognition. There wasn't really a significant difference in like how these people felt or how they functioned in day-to-day life. So, it's again, it's a fairly intense procedure again, because you have to get those imaging studies, you might have brain bleeding, you have to get your MRIs done regularly, you have to go in for your infusion every 2 weeks. Right now, the only center in California that's giving infusions is Stanford. The University of California institutions aren't doing it yet. You wouldn't be able to, if you were going to be from here and do this, you would have to travel every 2 weeks for this and get all of your studies done down there. Again, there's a lot of controversy among experts, and we wonder, really, does it work well enough to justify all of the things that I discussed? And there seems to be some shrinking of the brain with the medication, and I don't think we're going to know for a long time what that means in the long term. And then there's a whole groups of people who are going to be less able to use this medication because they have more risk of the brain swelling and bleeding, including people with Down syndrome. And people with Down syndrome are extremely high risk for Alzheimer's disease. It's almost, if you live long enough, you're almost guaranteed. And then people who, going back to those tests we do, the people who test positive for that APOE gene are also seem to be at higher risk for developing the brain swelling and bleeding. So I think it's great that people are studying these things. I think jumping on the bandwagon before we really know that it's going to do more good than harm is it's something we need to discuss as a society for sure. So should you take this? I would say with people who have that mild cognitive impairment, very early dementia, who have access to it, can afford it, understand all the risks, including brain bleeding, potentially death. There's a lot of things that need to be discussed between a physician, patient, and their family around whether this is worth giving a try. This is kind of a busy slide, but just pointing out that if you go to the store, or go online, you'll see lots of treatments that are touted for memory. And it's important to remember that supplements are not FDA monitored. So they don't need to be tested. There's no, there's just basically no safety net there in terms of what they're claiming to be. So I personally am not a big fan of supplements. However, there are some studies that do show, that antioxidants are helpful. And we know that, for instance, these things that I list here, vitamin E, for instance, is an antioxidant. It might help a little bit. It's harmful at higher doses, and again, bleeding and hemorrhage in the brain. I think the take-home message is, if it sounds too good to be true, it probably is. If you're going to start a supplement, it's good to talk to your doctor about it, because they can also have interactions with other medications. And then more is not necessarily better. But vitamin E may have some help in decline. This is interesting. This actually just came up this year. There's, again, another controversial area in our society is vaccines, but this scientific meeting called the Basic Cardiovascular Sciences Scientific Sessions, where a bunch of research scientists get together and talk about the work they're doing. There was a presentation this year from a group in Tokyo around this vaccine that it's only been tested in mice. And it's basically targets these cells that express senescence-associated glycoprotein, which is basically, senescence is aging. So it's something that adds to damage of cells. And what they found is, if you vaccinated the mice, they had less of these amyloid deposit and less inflammatory markers. And I mean, you might ask, well, how can you tell clinically how that makes the mice do? They did have some observational behavioral things with the mice that it appeared that the mice who received the vaccine did better than those that weren't vaccinated or got the placebo. And again, to me, this is exciting, because we're starting to sort of touch on another potential tool, but I think we're a long way from giving people vaccines. I want to talk a little bit about research besides treatments. One thing that people may have heard about or experienced at the doctor's office is getting tested for dementia. And there's different tools that we use. And the tools that we use, like if the mini mental status exam or the MOCA test, those are used in the doctor's office only after they've gone through research to validate them and study them and see how accurate they are. This one, the clinical dementia rating scale, looks at basically how people are functioning. And we do need to continue studying in a more diverse population. A lot of these have been studied in pretty homogeneous populations. But it's important to know about these tests because when you look at, say, those infusions that we were talking about for treatment, when they say people scored better or had a less of a decrease of the score, they're talking about these types of tests. So the tests, that questionnaires that people are doing are what the scientists are basing, is this drug working or not on. This is another really commonly used one. It's available in a lot of languages. It seems to be especially good or sensitive at picking up people who might have some problem with that frontal area and problem with language. It's been validated in people 55 to 85, and it is somewhat biased towards people who have a higher education level. This is the one I'm tending to use these days, the RUDOS, mainly because it seems to be less biased towards education, culture, gender, and language. Fairly sensitive. If you'll see that low number, though, for specificity at 54%, what that means from a scientific standpoint is just because this test is abnormal doesn't mean you have dementia. And I'll talk a little more about that, but that's it's just a tool to get some objective measurement, but there's a whole lot else that goes into actually making a diagnosis. And then again, this is another really commonly used one. Again, now it's mostly been tested in white male VA patients. The good thing about that is they tend to have a lot of medical problems, so it might be more applicable to people who have a lot of chronic medical issues, but again, very homogeneous group of people. Another thing I want people to come away from this is understanding screening versus testing. So most of those tests that I just talked about are actually tests because we're doing them in people who either say to us, I'm worried about my memory, or a family member saying, I'm worried about mom's memory. And a screening is really something we do when someone has no symptoms. So think about, like, if you get sent for a mammogram or you have colonoscopy or a pap smear, it's like your doctor saying, oh, you're due for your mammogram. It's not because they're worried about a lump or something like that. So it's actually, when it is for that, it becomes a test, not a screen. At this point, there's not clear direction to doctors about whether we should be screening everyone for dementia. And again, I want to emphasize that just because you score abnormally on one of these tests does not automatically mean you have a diagnosis of dementia. It's just a piece of information. Another way to test is, I hate this term, but an informant questionnaire. So this is similar to those other tests. It's been validated, but instead of talking to the person themselves, they'll talk to that person's loved ones or care givers, friends, and to try to see if they meet criteria for some cognitive dysfunction or memory loss.
I have a question. Or
sure, go for it.
Someone asked for me to ask you. This comes from Evelyn. She says, how much does inflammation from autoimmune diseases contribute to dementia?
It's a great question. So kind of back to that, there's at least 70 different causes of dementia. If there is something that's inflaming your brain, like an autoimmune disease, it potentially could damage cells in the brain, which could potentially lead to one of those sections of the brain not functioning as well, which could lead to the symptoms of dementia. it's very hard to say in, you know, in any, in a grand way, you know, that everyone with brain inflammation from autoimmune disease is at risk for dementia, because it would need to be studied, right? We'd need to look at that specific population. But anything that affects brain health, and I'll talk a little bit more about this, but whether it's what you brought up or head injuries, look at football players who have a higher risk of dementia related to recurrent concussions. You look at smoking cigarettes, which affects the blood vessels in the brain, high blood pressure. I mean, there's a lot of different things, alcohol use, all of those things can contribute to brain cell damage. So again, if someone has an autoimmune disease, I wouldn't say, oh, you're going to get dementia. I would just say, let's make sure that we control what we can and take the best care that we can of the autoimmune disease and of your brain in other ways. Does that answer the question? All right, I'm going to keep moving on, but I'm glad to discuss that more if it would be helpful. Other research, this is actually from one of our local neurologists, Dr. Iverson, who some of you may know, around one of the things that we often get asked as doctors is, should I or should this person be driving anymore? And so he did a review of studies that kind of looked at criteria for telling whether someone's at higher risk for problems with driving. And basically the things that were associated with more likely having an accident was a caregiver reporting that I don't feel safe when they're driving. Their score on one of those tests that we were talking about, having a history of problems with driving. The self-report of the person is just like, I'm not driving as much, or I'm trying to just drive in this small area. Again, another test, the mini mental status, and then a person who tends to have more impulsive and aggressive stuff. So this just shows research is not just about treatment, but trying to understand better like how we cope with some of the day-to-day realities of this disease. Another thing that's been studied is wandering. This is important because a lot of times wandering, which means someone leaves their place where they live or wherever they are and kind of gets lost. And especially scary if it's after hours or it's raining out or it's cold. So it often ends up being where we start talking about having to put people in congregate settings, or what we call placement. So people have been looking at this some, and what we found is everyone is at risk, maybe men more than women. It's interesting to me that a caregiver is often around when people get lost. Obviously, having constant supervision can decrease the risk. Day centers like we have here at the Senior Resource Center can be helpful. Sometimes use of a tracking device can help. And the Alzheimer's Association actually have a 24/7 wandering support service. There are some fees involved with it, but I recommend going to this website if you're interested. One thing that I talked to my team about is, placing someone in an institution doesn't necessarily automatically equal less risk. So people can still walk out of there, people can still fall there. So one of my hopes is that our society can just be better about supporting people with dementia and their families. Living alone is another one. So I'm a big fan of people living independently for as long as they can. And there's some people that I've studied looking at how we can predict who might not do well with that. Very small study, 139 people, followed for 18 months, 65 years and older with memory loss. And the people that didn't do as well, again, had lower score on one of those tests, the mini mental status exam. They had other disease processes that affected their health and less social supports. And in the study, there was some incident of significant harm in about 21% of people. Now, what we're not looking at here is if the people were placed, if they weren't living alone and they were placed, what percentage of harm did they have? And the most obvious example of this recently is in the pandemic, where a high percentage of sickness, illness, and death in COVID with people that were in congregate settings.
I have another question from Evelyn.
Sure.
They ask, can you discuss a little bit about the connection between Parkinson's dementia and amyloid plaques?
Yeah, so Parkinson's disease, sort of like Alzheimer's disease, named after a doctor who was involved in the discovery of it, has a real spectrum in people. It's, affects the part of the brain that is involved with dopamine and movement. And so one of the prominent things we see in people with Parkinson's is a tremor and difficulty with moving, walking, getting up out of a chair, that kind of thing, facial expressions. The dementia in Parkinson's disease is not, it's not in 100% of people with Parkinson's disease. And there's likely a fair amount of overlap of Alzheimer's type dementia and Parkinson's related dementia. But the dementia that we traditionally associate with Parkinson's is called Lewy body dementia. And this is a different type of deposited protein that causes cellular damage, and they're called Lewy bodies, after yet another doctor, Dr. Lewy, that are seen on, under a microscope in the brain. And there's slightly different clinical, presentation with Lewy body type dementia. It tends to really affect the back part of the brain that is involved with visual spatial things. So it can be hard for people to put their clothes on or go downstairs because they're just not, that sort of where am I in space thing isn't working as well. And there tends to be more hallucinations and then more ups and downs. So people with Lewy body dementia can have a really good day and a really bad day, and they can have a really good hour and a really bad hour, whereas it tends to be more stable in people with Alzheimer's with a slow decline over time. So it's slightly different parts of the brain, slightly different syndromes, but in my experience and most of the neurologists I've talked to, there tends to be an overlap between Alzheimer's and Lewy body Parkinson dementia. It does become important around some medications that we use because we know if someone's predominantly Lewy body versus Alzheimer's, we're going to look at how to treat it differently. And there's certain medications that we want to avoid in people with Lewy body dementia, particularly around some of the older antipsychotics, which does come up because of the hallucination issue. Okay. I'm going to move on here. We're talking about research. The question is, how do you get people to be involved in research? If you go back to that study I just talked about where they looked at the risk of living alone with memory loss, it took about 3 years for them to recruit all of 139 people. And you have to look at, people need to consent to the research, which might be hard if you have memory difficulty, and people might be reluctant to sort of out themselves for fear of losing independence. And I think it's a valid concern. People are stigmatized for memory loss. They're afraid of what they're going to lose. So I think finding ways to bring people safely into research is important. It's the only way we're going to better understand the disease, how to treat it, and how to best care for people. Another area of research is around financial capacity, a big, huge concern for people. Risk for people taking advantage, difficulty with managing finances. So there are studies that have looked at it, but one of my interests would be is how can we promote financial independence for as long as possible. Again, it's just something we need to think about. Behaviors is a huge area of research right now, actually, and behaviors basically is around where people might be agitated, and that can be really difficult for family and caregivers to deal with. And generally we turn to medications, but what we know about the medications is that they can cause a lot of harm in people. So there's definitely, there has to be a discussion around, sometimes the medications have to be used and it might let people remain at home longer than they would otherwise. Generally, it's antipsychotics that we look at. We do know that people who have dementia who take antipsychotics for behaviors have a higher risk of harm and death with them. But again, the trade-off may be that they have a better quality of life and they're able to stay in their home setting, and families able to take care of them. There's another type of medicine that works differently than antipsychotics that have been looked at, especially in people with more of the Parkinson's related syndrome. It's somewhat promising, but it's a very small study. It's not really ready for prime time. But again, this is a very active area of research because it really affects people's day-to-day life. I want to lead people to go explore Teepa Snow's work. Here is her organization, The Positive Approach to Care, and you can Google this and go online. And you can also go to YouTube and just Google or put in a search for Teepa Snow, and there's many videos. She trains family members and professionals around caring for people with dementia. And part of the cool thing too is this organization, Positive Approach to Care, has people with dementia informing like what works best. And really this long arc of trying to work toward treatment and cures does not tend to the problem right now, which is how can we serve each other and how can families deal with the stresses, the economic concerns, and how can we be a more friendly society, basically for both for caregivers and for people who are living with dementia. So Teepa Snow, she is amazing. I've seen her speak in person, and she's an occupational therapist and an expert in really day-to-day caring for people. Again, just reminding people, if it's too good to be true, it seems too good to be true, it probably is. You can find all sorts of pills, phone apps, etc., around brain health and dementia. It's a big business. This year, probably $5.8 billion worth of sales in this. And I just, because it's expensive just to, be working and taking care of someone and just having the day-to-day help you need, there might be better ways to spend money. That's my opinion and the opinion of a lot of specialists. That being said, I think it's kind of cool that people are looking at alternative ways to promote brain health. And this is actually a study that was done on a very small group of people, but around using virtual reality games. And I think what's cool about this is people in the study would wear the virtual reality and played these games at higher and higher levels of difficulty, and it involved having to move your body. And I think what we see is that memory and your physical self are linked. And we know that exercise, for instance, can be helpful in reducing risk of dementia and helping people be more functional. Anyway, this is just kind of a fun area of research. A lot of people want to know, how can I keep myself from getting dementia? And I mean, there are some studies looking at what we do earlier in life as affecting us later. I think that, you know, as a doctor, not just around dementia, but just around all chronic illnesses, there are some behavioral things that could reduce risk: not smoking, exercising more, eating healthy. It's really important, though, that, you know, it is not the fault of people with dementia that they have dementia. It's just that there's so much we can't control about it. So I try to think about, like, you know, what can we control? And these are the things that potentially we can have some power over. Alzheimer's disease risk. This is a slide from the Alzheimer's Association, which is also a good place to go for information. And, you know, again, it's like, if you're not hearing well, we know that people who have hearing loss, who don't have that, tend to have a higher risk of being diagnosed with dementia. If you're drinking alcohol, that's like Evelyn mentioned, autoimmune disease. Alcohol inflames the brain and kills brain cells, so that's going to increase your risk of dementia. Same with cigarettes, uncontrolled diabetes, uncontrolled blood pressure. So all these things, again, that we potentially can have some impact on while we're waiting for the cool new drugs to come out. A reminder that a lot of these things for brain health, you don't actually have to buy them. You can just add them to your repertoire without having to buy them. So doing things to you know, challenge your brain. People talk about crossword puzzles, but really just any new thing. So I encourage people, whether they've been diagnosed with early dementia or they are just interested in protecting their brain, like learning something new is a really good way to help protect the brain, because it's the brain is very it's always creating new connections. It's pretty amazing, actually. We call it neuroplasticity. Sleeping is also important, so tending to that. And a huge thing is connecting to other human beings. And our current Surgeon General is actually talking a lot about loneliness as a huge impact on people's well-being, and that includes cognitive status. So what goals should we have in terms of doing research? Obviously, cure, prevention is important, and that's really where the money is. I mean, that's what the drug companies want us to do, and we all want it, right? But I do think there's other areas that might be important to study, and that includes the day-to-day symptoms, the burdens on people with dementia and their loved ones, and then again, looking at the way we have our society set up, which, you know, our society is set up for people who are young, productive, and don't have any, like, disability. And the reality is almost 100% of us are going to age and have disability at some point, and we just don't really like make room for that in our society. This was brought up in the World Alzheimer Report in 2020 around looking at sort of how we take care of people with dementia, and there are people really interested in looking at globally at, like, ideas for designing areas of care for people with dementia that are better, that are more stimulating, that you know, are culturally appropriate. And I think this is super cool. This was actually there's an article about this in the New York Times earlier this year as well. So I think in the future, like, we'll see a lot of work on cure and prevention. We do need to people to participate in trials and to fund them. And I think we should demand from our legislators that they support research around this disease. And even though it's kind of depressing that so far we don't have, like, the magic bullet, even trials that don't work, give us information that help us move to the next step, move forward. You can go to National Institute on Aging as well as Alzheimer's Association and sign up for trials for people who have dementia, people who don't have dementia. We need to study everyone, so maybe go to that and volunteer to be in a trial. The more research, the better. And like I said, in the meantime, we should be supporting each other. Promoting independence, I think, is really important, and rethinking, sort of our tendency to want to institutionalize people and thinking maybe there's ways we can design our society so people are able to stay in their home setting longer and be a part of our community. So thank you. This is my uncle. He died about 2 years ago with dementia. And, so all of us are touched by this, right? There's rarely a family that doesn't have someone that they love who is, or themselves, that have dealt with this. So I think it's really important to continue working on research to do better. So I am open for more questions if people have them. It sounds like there was some interest in other types of dementia. I don't know if people have further questions on that, or Caitlin, what do you think?
I have a couple questions that went through the chat box to me that I wanted to pose to you, but I also wanted to step in briefly. The person that was talking about Parkinson's, I told them through a direct message, but I want to tell everyone else that we do have a presentation on Parkinson's from Dr. Andrew Levine that's available on the YouTube channel from an earlier Lessons in Dementia workshop. So there were a couple questions in regards to behaviors. Linda was asking if do you have any practical suggestions for behavioral modification?
Yes, my most practical suggestion is to go to that TIPA Snow website and YouTube and look at her videos. I kid you not, she's a genius around this. And what I love about it is she really puts you in, sort of flips the narrative. So you think, oh, someone's getting agitated because I want to bathe them. How can I bathe them when they're agitated? It sort of flips the narrative toward what someone who has a brain where the visual spatial centers and the processing isn't very good, and someone's coming at you to do a very intimate thing, like how that feels. And so our approach to people needs to have some understanding of sort of how it feels to be on the other side of that, where things are just not being processed in the way we're used to processing them. One thing that like a real quick thing that she does is she'll have you do this. And, like people with brain dysfunction, often this is how they see the world. And so when someone comes at them from the side or suddenly, it's very jarring. If you just do this and have someone sort of approach you quickly, your reaction is going to be agitation because you're like, what the heck, you're in my space, I have to direct you to Tipa because she's got great answers. And probably, I don't know, Caitlin, there may be some another video or session on this as well.
I did a session back in March that addresses some more practical approaches to different things such as agitation and sleep loss and things like that, which is available on our YouTube channel. And Claire Day also posted in the chat that there's, I believe, an Alzheimer's Association workshop coming up regarding behaviors. And then another question came from Kim. What about Rexulti for behaviors?
Yeah, so there's not really any medication that we have enough research on or experience with to feel comfortable saying any of them work for behaviors. That being said, we do use medications. it's sort of like, in my mind, very specific to the person, their other medical problems, the other medicines they're on, the types of behaviors they're having, whether they're having hallucinations or not. Yeah, there is no great pill for it, but there are various medications that we use. So I think that again is, I can't give a broad answer on that. It's really very much an individual discussion around that human being.
And then Wendy asked, is any gene editing technology promising as treatment for dementia?
Not yet.
No, I was thinking specifically to the dementias that have that genetic component.
Yeah, so that's, I think, hopefully where we're heading. And that study that is looking at, global study with over 345 scientists that's collecting as many genetic tests as they can of people with dementia is kind of the beginning of that type of research. And the tricky thing again is like, how do we gather all that data without hurting people in the process? I mean, genetic testing is a very kind of deep ethical question. And so although I'm excited that there's research in it, I think if anyone is going to get genetic testing, they really need to have a meeting with a genetic counselor, which you'll find at academic medical centers.
Thank you.
And then Linda also asked, how does COVID long haul fit in?
So that I would put that under the 70 is my favorite number today. The 70+ reasons that people might get dementia. Anything that affects the brain in an adverse way potentially can lead to the same syndromes we see, the same symptoms we see with Alzheimer's type dementia. So there's so much we don't know about long haul COVID. It seems pretty well documented that people can have brain fog. And I don't think we know yet whether that's a permanent thing or just for a while or for a couple of years. I mean, I think the jury's still out on that. My general recommendation around COVID is try not to get it and get the most recent vaccine, which is coming out probably this week. The more times you get it, the more chance of getting long COVID.
That was all the questions in the chat box. Thank you. Okay. Does anyone else have any more questions for Dr. Heidmann?
I see a hand up.
A virtual hand or
an actual hand,
an actual?
But I don't see a name attached to it. So can you see? Can you just start talking, person with hand up?
Change my view.
I don't know if you can hear me.
Yes.
I was approached by UCSF Memory and Aging Clinic for a clinical trial study for my husband. At first they wanted to put him on that anakinra, but we didn't do that. But then they came back with one that I have not heard of before. It's Celia. It's a spinal infusion. Have you heard anything about that? CELIA.
I have not. I'm wondering if it's in the same family though as the amyloid reducing agents. There's a lot of different studies going on around that. So I can't give any real answer to this except for as with any study or medicine that's being studied, I would have I want a lot of clarity around what the risks versus the benefits are.
Right.
But,
I kind of came up with the same, we just had the anakinra, the same reasons that you had listed, and the same thing for this one too. It's like, traveling to UCSF San Francisco every 6 weeks, and sometimes for MRIs, just it doesn't really make sense with the chance of a placebo and the risks
Mhm.
and,
Yeah.
you know, he still has a pretty good quality of life, so why spend it traveling? So,
That's, I mean, that's totally reasonable response. And, you know, it's hard. It's one of the hard things about being in a rural area like this. But even if you lived right in the city, those are questions you want to ask. And especially if there's a chance that something bad's going to happen.
right.
But, you know, that's the hard part about medical science. You know, any treatment that we now use regularly with people at some point was in a testing phase, and we need people to test it in order to see if it works. But yeah, I think especially for people in Humboldt County, like I would want to know that there was a really, really, really good chance something good was going to come out of it to make that kind of commitment.
Yeah, and they seem, you know, the drugs that are out there now just seem so low for
Unfortunately, that's
all of
true.
that.
Yeah. Hopefully it'll start to get better. I mean, like I said, I'm trying to be, you know, when I got asked to give this talk, there's a part of me that always sort of dreads giving this talk because I don't have a lot of good news for people. But, you know, I think I like to remain hopeful in life. And I know that there's a lot of people that really care about this. And I feel like we've gotten through, like we're in a new phase of research right now that's a little more sophisticated and hopeful than we were 10 years ago, even 5 years ago. But yeah, we have a ways to go.
Yeah, you want to help science, but on the other
Yeah.
hand,
Yeah,
you have
yeah.
one life. So,
absolutely.
okay, thank you.
We had one question pop in from Linda, and she talking about practical issues and saying that she's placed people and in dementia units that are unable to assist, and suggestions on like where they can go.
So that you're saying that dementia units aren't always what you hope they would be? Is that the question?
What it sounds like from the message.
Okay.
Yes.
I mean, yeah. This to me is this whole area around how do we take care of each other as we age, and with this very common disease. And unfortunately, you know, the units that we have, so dementia units in general tend to be units that have more like a lower more staff per people and more kind of eyeballs on people, and then they try to keep people from wandering away. So that's sort of the definition of a dementia type unit. And it's hard because the reality is it can be really almost impossible for a family member to do all the care for someone who has dementia on so many levels, like emotionally, physically, economically, you know, and so we don't have a lot of choices. You know, one of the choices are out there is the PACE model, the adult day model, where you can get some respite. But eventually some people do have to go into congregate living. And I guess really just trying to be an advocate for that person, knowing that it's going to be imperfect. I mean, my experience of people who work at those units is that they have good intentions and they really do care about the people that live there. But, you know, another aspect of our society is that caregivers are some of the lowest paid professional professional people. And so I just think there's a big disconnect there, you know? I mean, who can you really think is more important than the person taking care of someone you love, you know? So I don't have an easy answer except to say I feel your pain, and I think being a bee in the bonnet of a place where you have a loved one is appropriate. And you know, ideally we could all have extra help at home and have our loved ones stay home, but you know, it's very expensive. It's really hard to do. And yeah, remember that there's ombudsmen out there. Those are people that are basically advocates, professional advocates for people who are in dementia units or nursing homes. If there's any concerns, they should be contacted, and they can help advocate for people as well. So you don't have to do it on your own.
Last call for questions. Well, thank you, Dr. Heidmann, again for offering your time and knowledge today. It's greatly appreciated. And I just wanted to remind everyone about the survey at the end of the workshop. And our next Lessons in Dementia workshop is on October 16th with Dr. Ann Lindsay of Life Plan Humboldt. And she'll be presenting on clarifying goals of care for someone with dementia. So a great follow-up to this, I feel.
Great. Thanks, everyone.
Thank you, everyone.